Then let's study about this drug which is Ranalozine. So this novel anti-anginal drug, how does it act? It acts by inhibiting late sodium currents in myocardium. Because sodium currents are inhibited, what happens? It is going to in myocardium, which indirectly facilitate sodium entry through sodium calcium exchanger. So basically ranolazine is inhibiting late sodium currents. Only if late sodium currents happen, calcium entry is supported through sodium calcium exchanger. Whenever you are giving ranolazine, all this doesn't happen. So there is reduction in calcium overload in the myocardium, especially during ischemia. So what happens to contractility? Contractility decreases. So it has a cardioprotective effect. There is dash of fatty acid oxidation. So there will be sparing of fatty acid oxidation during ischemia in favor of more O2 efficacy carbohydrate oxidation by inhibiting what? By inhibiting LC3-KAT has also been demonstrated. So this was earlier believed to be the main mechanism of anti-anginal action of ranolazine, but is now considered secondary. So the first thing is it is going to inhibit late sodium current and thereby it inhibits the entry of calcium through sodium calcium exchanger. And there is one more action, that is it is going to spare fatty acid oxidation during ischemia in favor of more O2 efficient carbohydrate oxidation by inhibiting LC3-KAT. Okay, these are the two mechanisms. What effect does it have on heart rate? Nothing. Effect on BP? Nothing, but prolongs exercise duration in angina patients. Then we'll be talking about the efficacy of ranolazine in decreasing frequency of anginal attacks and prolonging exercise duration has been demonstrated both as monotherapy as well as when added to conventional drugs in multi-centric randomized trials. We have a trial which is MARISA, which is monotherapy assessment of ranolazine in stable angina, and then we have CARISA, which is combination assessment of ranolazine in stable patients 2004, and we have ERICA, which is efficacy of ranolazine in chronic angina 2005. In Merlin Timmy 36 2007 trial on non-ST elevation acute coronary syndrome patients, ranolazine use was associated with a fewer rates of ventricular arrhythmias. Incidence of AF was also decreased. However, ranolazine prolongs QT interval and should not be used together with other QT prolonging drugs like class 1 or class 3 antiarrhythmics and other drugs listed. So the oral absorption of ranolazine is slow taking. It usually takes how much? 4 to 6 hours with bioavailability of how much? 30 to 50%. So it is metabolized where? It is metabolized in liver by what? By CYP3A4. It is excreted how? In the urine. So what is the average T half? T half is 7 hours. What are the side effects? Side effects are again dizziness, weakness, constipation, postural hypotension, headache, dyspepsia. It should not be given with patients taking DASH medications, CYP3A4 inhibitors. Can it be given to patients taking sildenafil? Yes, it can be given. So what is the dose? Dose is 0.5 to 1 gram BD as SR tablet.